My name's Rita Ledbetter, and I'm a certified nurse midwife that's practiced for 20 years in Moline, Illinois. I was born and raised in St. Louis. My husband's job, he was a railroader. We were transferred. He was what they call the general car superintendent, so he was responsible for all the safety measures on the railroad, and if there was a hazardous material spill, he had to go help clean it up. I'm used to train sounds. We lived in a railroad town for many years. We moved there in 1984. We have three. I have a 40-year-old and a 35-year-old, and we have a surprise baby who is now 22. We waited 14 years for her, but she came along at a time that was very interesting.
Why was that interesting?
Because I had just entered midwifery school. That was fun. Go to midwife school and you get pregnant.
Gee, that's never happened before.
Never. I'm sure that's true. It's all those hormones, you know that. All that talk about sex. You know, I'm one of those people that believe they were called into it. My mother had a family medical guide, and there was a chapter in there on pregnant women, and I very much distinctly remember that you shouldn't vacuum when you were pregnant. I remember that being in the book. And I remember having Barbie dolls, and nobody in my family sewed, but I would take the Barbie dolls, take their heads off, take a triangular piece of cloth, fold it in half, cut a neck out, put it on the Barbie dolls, and stuff cotton balls up the front of the Barbie doll's dress that I made them. I made them all pregnant. I was 8 years old. It very much concerned my mother that all my Barbie dolls were pregnant. And then I would take care of my Barbie dolls. I have no idea where it came from, but that's what I remember. And in 8th grade, I made a pictorial, drew pictures of fetus, and did a book. I have it still. We found it in the basement. I did a pictograph of developing fetuses in 8th grade. So where it came from, I don't know. I believe it's a calling. I'm Christian-based. I think God said this is what this girl's going to do. I think he put the passion there. He put everything there. I say that I lived in a ghetto in St. Louis. My mother said it's not a ghetto. We were never poor. Of course we were never poor. But what happened is I wasn't socialized to be a doctor. I wasn't socialized to be anything else. So the only thing I thought about is I could be an OB nurse. I didn't know about midwives. I didn't know anything about them. As I grew older and I went to work at St. Mary's Health Center in Clayton, I became aware that there was a midwifery school at St. Louis University. And all of a sudden something sparked in me, and I'm like, I've got to go there. And I proceeded to start to take classes to go to St. Mary's, or to leave St. Mary's and go to St. Louis University, and my husband got transferred. So we ended up at that time in Galesburg, Illinois, which did not have any schools near it at all. I had started at St. Louis U, but nothing transferred to the new college there. So then I felt very stymied and upset until I ran into a woman who was going to nurse midwifery school at the University of Illinois and said I could commute, which was only 3 hours away. And I had a way of doing what I'd always wanted to do. So it was quite a pathway. I commuted for 2.5 years and then worked a little bit on a PhD, commuted a little bit longer. And by that time, our little girl was becoming old enough that mommy was gone too long. So I'm happy with where I stopped. I stopped before a PhD, but I did graduate. I was very, very fortunate. When I went into school, we had no idea where I was going to work. The town where I wanted to work, or our current town, had one doctor who had worked with midwives. He actually delivered my baby. And I worked at that facility, and he had worked with midwives in England, and he didn't have a very positive feeling about it. So when I graduated, I had no idea what I was going to do. And while I was in grad school, I had worked PRN at several hospitals. I had stepped down from a head nurse position right after I graduated. And I was very fortunate to be offered a position 45 miles away. But my husband could not leave his position because he had to be very close to a computer. So I ended up commuting to a job 45 miles away. and that's the same job I'm still in. I had 4 different job offers that came out of the woodwork, but this is the one I chose, and it has worked out very well for me. It's about 2/3 of an indigent practice, so we have very low income Illinois public aid women. We actually won an award from the state because I joined 2 other nurse midwives at that practice, and we had kind of just a wonderful practice called Trinity Maternal Care Center that had nutritionists, we had social workers, we had unbelievable outcomes, really good outcomes, won an award. Our other 1/3 of our patients were very yuppie, very informed, so we would go from, you really shouldn't use that much cocaine during your pregnancy to, really it's okay to have a cup of coffee a day. And we do that in 1 day. It's always been a hospital-based practice. At that point, we didn't have very many epidurals. Of course, 20 years later, it's a little bit different. But the practice mix is still about the same. The practice is very supportive. I love my patients. I've been very empowered there. I've delivered 5 and 6 babies from the same women. I feel like we've made a difference. And respect. I grow nurses there. I love what I do. Because we truly make a difference. I just last year, when I first joined the practice, had a teenager in the group, and she went and had a baby girl. Very difficult labor, very difficult OP labor. She even says I was very mean to her in labor. She remembers that. And I made her get out of bed, get in the shower, get in all these positions. But she birthed a baby that was about 9 pounds directly nose up. And she had kind of a difficult tear, but she had her first baby. She didn't have a C-section. She went on to have 3 more babies. Now, she had a best friend that came to the clinic with her, which we had the TMCC, who did not follow the same life path. But Janelle went on to become a nurse because she was inspired by the fact of our group of nurse midwives were so nice to her. Again, a very poor child. She went on to become a nurse, and she just joined our practice last year. And she nominated me for an A.C.N.M preceptor award, which was very gratifying because I've precepted many students, the most of the students that are practicing around us. And because we're downstate and away from a university, she felt like we needed downstate midwives aren't acknowledged very much. So that was a very gratifying thing to happen. And I think that it made a huge difference in her life and a lot of other lives that they had women that believed in them and mothered them when they were in very vulnerable positions. Our group was known to do things like when a woman was having a very difficult time, maybe they came in preterm labor and they were on cocaine or pot, we stole one girl's shoes so she couldn't leave in the middle of the winter. Oh, you couldn't get away with that now. But it changed the outcome for her and the baby. We just wouldn't let her leave. And I don't know if I'd have the energy to do that now, but I'm very proud that we did it as a group. Outcomes, low C-section rates. What I'm most proud of is a sad story. I had a patient with endometriosis, and she had had such bad periods for so many years that she didn't recognize that she had endometriosis. She had infertility related to the endometriosis, and I told her that about 5 or 6 years before it was actually diagnosed. Then she went off to an infertility specialist, got pregnant, and she said back to me, "You told me this years ago. You said this years ago." Anyway, after that much infertility and a lot of other things that had happened bad in her life, she got pregnant with a little girl named Charlie. But at 32 weeks, Charlie stopped moving, and Charlie was gone. And I got the call from her, and her husband was a nurse by that time, and said the baby hasn't moved all day. My husband went to work and got the Doppler. We can't hear heart tones. Now, I lived 45 miles away. So I said, I will be there. I will meet you at the hospital. Of course, she got there before I did. The nurses listened for the baby, couldn't find the baby. They said, we need to order an ultrasound. I said, not till I get there. So I walked in and the ultrasonographer was waiting outside of the door. And remember, this baby was more than wanted. This was an in vitro baby. This baby was highly desired. Two people that loved each other. They wanted this baby. And so the ultrasonographer and I walked in the door and we diagnosed that Charlie was gone. And the wail that came from those two was a cry.
Okay.
I don't remember what I said, but what I said to them, they talked about at a share group meeting. We have a celebration in our town once a year, and they said that all Rita did was let us scream. And she said this to us, and I don't remember it. She said, someday you will be here with a baby in your arms, and that baby will cry. I don't remember saying that. I think it was part of my calling. It didn't come from me. And they went on to have baby boys, twins. And so I'm most proud of that I've been used well. I'm most proud of that in that moment where it was really a primal scream, that I somehow knew what to do. And those are the moments I'm proud of. I believe it's from God. A lot of midwives do. I'm a Christian. I believe that it's not the right thing to say to somebody who's had infertility for 10 years with a newly diagnosed stillbirth that they're going to have a baby. I mean, what if that didn't come true? I mean, that's not the right thing to say. But it was the right thing for them. And it was the right thing for me to do at that moment. Just fatigue, and I think as midwives we like to give ourselves away too much to our clients. Finding the space to be myself, finding space for my family, finding the energy after a day to go home and take care of them. I think for me, faith is a sustaining value. It's what keeps me going, what has empowered me, enriched me, knowing whom I believe in, and feeling very rich in that. I've studied theology quite a bit. And I should exercise more. One study said that a lot of us have this type of fat because of stress. And that's something that we need to work at. But that's relatively new information. I could have done better with that 10 years ago. I would have known about it. Well, the one thing that's recently come up that's been a little bit challenging is that many of our patients still don't choose epidurals. So we take care of them for the full, 7 to 9 months before the birth, and we're hearing their voice that they don't want an epidural, or they want a non-interventive birth. And so at this point in my career, I live close to the hospital now. We moved there about 3 years ago when my husband retired. So I have the advantage of I don't have to be there from the first moment they arrive. So I'll get a phone call from a nurse and they'll say they're here, they're 2 centimeters, they want an epidural. Now this is the patient that I have heard her voice for 9 months. And I will say to them, okay, if she's that uncomfortable, I'm coming in. And I recently had pushback from a nurse that said it's their right to get an epidural. And I said it's their right to have their midwife there to talk to them first. So I've been kind of a little bit challenged by that. We've got a brand new slew of young nurses that don't know a lot about labor support. So I've kind of asked around, is that a wrong thing to do, to make sure that they hear from me, or that I'm there with them and can work with them a little bit? I only have to wait maybe about 20 minutes for me to get there. But the majority, when I get there and I get them off the monitor, get them in the tub, or in the shower, or breathe with them for a while, or I talk them down from being so scared, and they do fine. So that's been a little bit of a challenge because I want to do what's right for that patient, not what's right for me. But that kind of bugged me that is it, yes, if I thought that's what they really wanted, I'd say go ahead and do it. But I don't think they're reacting to what they really want. I think they're reacting to the situation. It is challenging. You want to do the right thing, but you don't always know if maybe you've not heard them correctly or if that's what they really want. And culture has changed. The nurses are very wedded to getting good satisfaction scores. But that good satisfaction score is not just by keeping a patient quiet, as you said. It's about allowing them to be who they are. You know, labor hurts. Nobody's going to deny that. It hurts. And if anybody's going to call it discomfort, they're going to lie because it hurts. And it hurts in many different ways. But if you can comfort someone when they are hurting, they can cope with the pain and they feel cared for versus not helping them to cope when they feel alone, and that increases fear. I think when we build and develop a relationship with that woman that we've heard them, they know us, they're comfortable with us, they know that we're going to be there for them, and we walk in the door, we can get them to do things or to accept things that maybe the nurse that just met them cannot. So I think pain is relative to the amount of comfort they're giving. So when we're there rubbing their back, coaching them through, using other tools like aromatherapy and water and massage, and just lowering the level of the anxiety in the room, they can cope with what's going on. I've done this for over 30 years. We never gave pain medicine ever in the early years till they were 3, 4, 5 centimeters. It just was unheard of. And it's a totally different deal right now where you get pain relief on demand. And I think that's one reason our C-section rate has gone up. So if we can learn the art of comfort again, and the art of empowering that woman, just having a litany saying you're going to get done, you're okay, this pain's not to hurt you, this pain's to get your baby here, oh, that's a good contraction, that's mean you're opening up. That litany creates almost a hypnotic situation where I'm calm, they're calm, the family gets calm. We don't have a Jerry Springer baby story, oh, the cord's going to be wrapped around the neck kind of situation. The whole room settles down and it makes a huge difference, and that woman is able to cope. It makes all the difference in the world. We're not going to fix everything with drugs, and I don't disagree with drugs. I just think that there are other ways of helping women besides just drugs, and they don't want just drugs. They want somebody to care for them. Oh boy, there's so many ways to say that. The heart of midwifery is one woman communicating with another woman. Or shall we say one individual communicating with another individual. I have said that when I walk into a room and a woman's in pain, I almost feel affection for her. And that is a very bizarre emotion. I think it's something that's intrinsic to midwifery. Instead of running away from it and being scared of it, we feel an overwhelming desire to help. Kind of when somebody sees a wounded animal, you want to do something to make it better. But there's a connection that occurs right there. Something emotionally that she knows that you care. And you know that she needs you. But at the same time, you know that she's strong enough to do this. You just need to let her know that she's strong enough. And if you can get that going on, if you can get that vibe going on, it works. So the heart of midwifery is that connection that the care provider has with the person that's in labor, or the person that's experiencing a difficult outcome, or the person that you have to give them bad news, they've got breast cancer. They'd rather hear it from you than that oncologist, because they start out with the premise that somebody cares. And that's what it's all about, that connection. And I don't think we should lose that in midwifery. Well, to be honest with you, there are some doctors that connect that well, that they deeply care. I think within them they are healers. And I don't know if you can always delineate between midwifery and doctors. There are some doctors that are midwives. There are some midwives that are quote-unquote doctors. But I think with midwifery, sometimes because we don't have the demands of the physician, that we don't have to go to the ER to take care of that ectopic pregnancy. We don't have to worry about all the other things that are going to walk in the door. We have time to take care of that woman. Our reimbursement does not have to be as high as a physician. So we have more time. We have more empathy. And most of us are taught in the nursing model of care, which is a little different than the medical model of care. So we think a little bit differently. So time, effort, nursing background, and the fact that we don't have to make as much money. It's a very simple thing. Well, I apply midwifery in growing the next generation. It's very important to me to precept students. It's very important to me to be nurturing of young nurses. And it's important to me to teach residents about physiological care. I think the other way we do is we kind of midwife the world. We do global midwifery. I think we're all about healthcare reform, opening access to women to get healthcare. And my funny story is I went down to the Coyote Ugly Bar, just got lost in downtown Nashville. And I walked in, and immediately my mind went to this young girl who was serving drinks behind the bar. And I looked at her and I said, "Do you have health insurance?" She said, "Hell no. I'm a waitress." And we got to talking. And I thought, this is a royal shame. So I think we tend to do things like that. It just comes up in our spirit. I have to believe a true midwife, it's her calling. It's not just a job. It's not the way to pay for a refrigerator. It's not the way to get the fancy car. And that's what I think makes a midwife. Not that we don't like those fancy cars. But I think that's who we are.